All right, so good evening, everyone. So, in this today's session, now the next half an hour, I will be discussing about the multiple choice questions related to the brain tumors. Okay, right. So, every one of you, am I audible? Is my voice audible to you? Just give me a thumbs up. All right. So, let me take up the first question of the discussion. And I welcome you all, and I just want you to answer this particular question. Thumb sign on CT scan head is seen in. The options are chordoma, metastasis, glioblastoma multiforme, astrocytoma. In which clinical scenario you will see this particular thumb sign? Right. So please answer this question. Okay, so can anyone of you answer this? Okay, so one answer I got, that is from Aditya, saying C, that is glioblastoma multiforme. Okay, so no problem, I'll just discuss this question first, and then we will come back to the discussion, that is the thumb sign. So thumb sign, let me tell you that this is seen particularly in a clinical scenario called chordoma. Right, in chordoma you will see this particular thumb sign. Now the question is, what is your chordoma? Chordoma, let me tell you, it is one of the rare type of the cancerous tumor. Right, it is one of the rare type of the cancerous tumor. Now yes, Avinash, you have answered it correctly, very good. And where does this particular chordoma originate from? It originates along the spine. Right, it originates along the spine from base of the skull, right, from the base of the skull up to the level of the tailbone. So anywhere in this particular spine, from the base of the skull to the tailbone, this particular chordoma will originate. And how are these particular nature of this particular chordoma? Remember, these are the slow growing tumors. Right, these are the slow growing tumors. Now, what does the CT scan of this particular chordoma shows? CT scan of the chordoma, it will show what is called as the thumb sign. Let me show you that particular thumb sign of chordoma in the CT scan. Okay, so this is the thumb sign what you will have in the chordoma. Yes, so if you can appreciate this, that will be better. You see this is your thumb, and this is the parallel image of it. Now what is that you are noticing here? Right, what is that you are noticing? Let me tell you what is that you will notice. Remember this very important point here, it is the sella chordoma. Right, it is originating from the sella. Right, that is what is sella chordoma. It is the one which is originating from sella tursaica. And how it will represent? It will represent as bony clival erosion. Right, bony clival erosion. That is what is your sella chordoma. Now within this particular sella chordoma, there can be also calcification of that particular tumor. Right, there can be even calcification of this particular tumor. Now this is about what is called as the thumb sign in the CT scan, which is seen in clinical scenario of chordoma. Now let me tell you, in the entire medicine we have two more thumb signs. Now we have a thumb sign in the ENT. What is that particular thumb sign in the ENT? That is enlarged epiglottis. Where do you see that? That is seen in case of epiglottitis. There also, if you take an X-ray, you will see the presence of what is called thumb sign. This is the thumb sign in case of the epiglottitis. Next, you will also come across the thumb sign in some gastrointestinal pathologies. Now, what are those gastrointestinal pathologies where you will come across this particular thumb sign is in clinical scenario of pseudomembranous colitis. Yes, you can see here. This is the thumb sign like what you will come across in a clinical scenario of pseudomembranous colitis or ischemic colitis or inflammatory bowel disease. So this is about what is called thumb sign in chordoma. Now, some of you were opting the answer as glioblastoma multiforme, right? Now, what I will do is in the next slide, I will just give you the basic classification of the tumors. How are these particular brain tumors classified? These are classified into gliomas and as well as non-gliomas, right? Gliomas and as well as non-gliomas. Now, in between these two, if you take which are more common, remember it is your gliomas which are more common. Yes, Avinash, craniopharyngioma, can it also present as thumb sign as pituitary is also in the sella turcica. But one important point what you should remember, Dr. Avinash, that craniopharyngioma is the tumor which is not originating from your pituitary gland. Craniopharyngioma is a tumor which is originating from Rathke's pouch and it is a supracellular tumor, right? So that point you should remember. Okay, so that is about your craniopharyngioma story. Now, coming back to this particular discussion of the brain tumors, so we have gliomas and non-gliomas, and gliomas are more common compared to that of your non-gliomas. Now, within the glioma again, we classify these gliomas into astrocytoma, ependymoma, medulloblastoma, and as well as oligodendroglioma. The multiple choice question that will be asked for you is, which is the most common glioma? Right, which is the most common glioma. Now, among this, let me tell you, the most common glioma is your astrocytomas, right? Astrocytomas, these are the most common type of glioma. The next question what they will ask you is, what is the most common type of astrocytoma? If you take this astrocytomas, we classify them into pilocytic astrocytoma and protoplasmic astrocytoma. And this, among these, the most common type of astrocytoma, it is your glioblastoma multiforme. So, if the question is asked for you, which is the most common intracranial neoplasm, the answer should be glioblastoma multiforme. The answer should be glioblastoma multiforme. Okay, right. After having discussed about the classification of the brain tumors, there is another multiple choice question asked on this particular brain tumors. Which is the most common neoplasm in brain tumor in the adults? Which is the most common brain tumor in the children? These are the two multiple choice questions. Now, if the question is asked, which is the most common intracranial tumor in adults? What is the answer? Just now we have discussed, that is glioblastoma multiforme. And if the question is asked, what is the most common intracranial tumor in children? Then that is also astrocytoma. But what type of astrocytoma is this? In children, it is your cerebellar astrocytoma. So remember this point. C for children, C for cerebellar astrocytoma. Right? Now, overall, if you take all the tumors in the brain, overall, if you take all the brain tumors, you see here, these are all your brain tumors: gliomas, meningiomas, pituitary adenoma, neurinoma, metastatic carcinoma, craniopharyngioma, angiomas, sarcomas, unclassified, and some of the miscellaneous tumors. Now, among all those, the most common ones are what? Gliomas. And within the gliomas, which is the more common one? That is astrocytomas. And next to your gliomas, the next most common tumor, if anyone will ask you, then the answer should be your meningioma. Right? The answer should be your meningioma. Right? So, going back to your first question again, right? Thumb sign on the CT head is seen in, it is seen in case of chordoma. Remember that point? Very, very important multiple choice question. And CT scan of your thumb sign, that, sorry, X-ray showing thumb sign, epiglottitis. X-ray abdomen showing thumb sign in case of pseudomembranous colitis. Okay, right. Now, Yes, I just want to give you people a rough idea what we are running on this Unacademy platform. On this Unacademy platform, with one subscription, you subscribe to any course you subscribe, you will be having unlimited access to all the courses. Second important point, we will be also giving you the practice tests. And the very important thing is, all of these are your live sessions. Compared to other platforms where we have recorded sessions, this is the only platform which is giving you the live interactive feeling. And those students who have missed that session, you can watch the recorded session later on. And all the things like whatever we teach will be available for you in the PDF format. You can download them, right? And you will be accessible to all the batch courses, even though if you subscribe to one particular course. Okay. Next, and what are all the various courses we have in the month of March? We have totally, if you take the clinical subjects, we have totally 48 courses. In paraclinical, we have 23 courses, and preclinical, we have totally 18 courses, right? And apart from this, we have batch courses, 6 batch courses, and practice courses, we have 5 courses. That means you just subscribe to one particular course, you will be accessible to all the courses. That is the beauty of this particular Unacademy platform. Now, those particular students, whoever are willing for subscription but willing for the discount as well, then you can just use my code, that is Raj1769, wherein you will have a 10% discount on your subscription. You have 1 month subscription, 3 months, 6 months, 12 months, and as well as 24-month subscription. But as the number of months are increasing, then the per month charge is reducing for you. That point you should remember. In any of other platform, you don't have this 1 month, 3 month, 6 month subscription pattern. It is only in Unacademy platform. In order to see for those students to get maximum benefit, we have designed it in the form of 1 month, 3 months, 6 months, 12 months, and as well as 24 months subscription. Okay, now coming ahead with the next question. We have a 50-year-old woman presenting with complaints of headache and feeling low for last 1 year. She is being treated for depression. Last night she had an episode of GTCS and CT scan was done, and this is the picture of your CT scan. What does this particular patient has? Brain abscess, brain infarction, meningioma, hydatid cyst. What is this? You closely observe that particular image, then you will be able to answer that. Any one of you, please. Right. Any guesswork? Brain abscess, brain infarction, meningioma, hydatid cyst. Right. So if none of you answers this question, then let me just give. Very good, Ravi. Ravi, you're correct. This is a meningioma. Right, this is meningioma. Why it is meningioma and how is it meningioma? Let me explain you. Now, if you can observe this tumor, sorry, this particular image, you can notice that there is a small tail. This is the small tail what you are seeing for this particular radio opaque substance. It's a hyperdense lesion. It is not hypodense lesion. It is the hyperdense lesion what you are noticing. Now, what is that actually? It is the extension which is coming from your falx cerebri. Right? It is a meningioma which is coming from your falx cerebri. The tail, whatever you are seeing here, is your falx cerebri. Now, what is falx cerebri? If you take the dura mater, we have 3 meninges: dura mater, arachnoid, and as well as pia mater. This is your dura mater. Dura mater, it will descend down between the 2 cerebral hemispheres. Right? The dura mater, it will descend down between the 2 hemispheres in the form of what is called as falx cerebri. So falx cerebri is nothing but it's a meningeal layer. And where is that present? It is present in between the 2 cerebral hemispheres. Now, whatever you are noticing here, it is nothing but it is the extension of your falx cerebri which is going down, right, which is suggestive of your meningioma, right? And if you take this particular meningioma, what is this CT scan showing you? It is showing you a calcified lesion which is originating from the falx cerebri, right, which is originating from falx cerebri. And what is a clue for that? The clue for that is the tail-like appearance what you are noticing. Where is the tail? This is your tail-like appearance whatever you are seeing, and that will give you the diagnosis of what is called meningioma. But now the question is, why is this patient presenting with GTCS? Why is this patient presenting with headache? Because the tumor is so large, it is an intracranial space occupying lesion, and it is causing raised intracranial pressure, right? It is causing raised intracranial pressure. Because of raised intracranial pressure, the individual can have headache and as well as GTCS, and it is almost causing midline shift, right? It is almost causing midline shift. You can see that here. Okay, now always the question comes to the students, how to identify the other lesions. Then how will be in brain abscess, what will be the CT scan in brain infarction, and how will it will be in case of hydatid cyst. Let me explain you. Now this is your brain abscess. Now what is that you will see in the brain abscess? What is that you will see in the brain abscess? You see here, it is a thin enhancing rim which is present around the lesion. See, this is your lesion, that is the brain abscess. So around the abscess you have a thin enhancing rim. That is how you will see the brain abscess. And sometimes there can be daughter collections also, that means small collections from this particular main collection. And if this particular brain abscess, if it ruptures into the ventricle, there can be even intraventricular extension. So this is how you will identify the brain abscess, that is rim enhancing lesion. So brain abscess is ruled out. Why? Because in our question there is no particular rim enhancing lesion. So your brain abscess is over. Then coming to your brain infarction. Brain infarction, if you see, this is your infarction. In case of ischemia is nothing but infarction. In case of ischemia, you will have hypodense lesion. It is not hyperdense lesion. You will have what is called hypodense lesion. But what do we have in the image? In the image, what we have is a hyperdense lesion. So that is the reason why your brain of infarction is also ruled out. Now coming to your hydatid cyst. Right, coming to your hydatid cyst. Now let me show you how the hydatid cyst will appear. Hydatid cyst, right? You see, this is your hydatid cyst. Majority of the time, the distribution of your hydatid cyst, it is in the territory of middle cerebral artery territory. And this is also a well-defined circumscribed spherical lesion, but it is non-enhancing. It is non-enhancing. One very important point which will differentiate hydatid cyst from meningioma is the calcification. In case of hydatid cyst, there is no calcification. But what we have learned in the meningioma, we have learned that there is presence of the calcification. So that is the reason why this is not even your hydatid cyst. So what is the final answer? That is your meningioma. So what is that you are noticing here? Calcification of the falx cerebri, and that can be seen in the form of a tail-like extension. And because it's an intracranial space occupying lesion which is large and causing midline shift, the individual is having headache, depression, and as well as vomiting as well. Depression is like non-specific symptom, not related to your intracranial space occupying lesion. Okay. Now we will move on to the next question. Right. Yes, Murugan, you're correct. Ball-like calcification. Right. We will move on to the next question. So the next question, if you see here, which is the most common type of primary CNS lymphoma in AIDS positive patients? The options are centroblastic large cell lymphoma. Second option, immunoblastic large cell lymphoma. Third option, anaplastic B cell lymphoma. Fourth option, lymphoplasmacytic lymphoma. Yes, who will answer this question first? One answer I got, that is C, anaplastic B cell lymphoma. Balamurugan, D, anaplastic. So majority of you with either C or D. Let me explain you this. So if you take this question, now you take this primary CNS lymphoma. What is our discussion? Our discussion is about the primary CNS lymphoma. If you take this primary CNS lymphoma, the presentation of the primary CNS lymphoma, it is different in immunocompetent and immunocompromised. So first we will see in immunocompetent. In immunocompetent individual, the primary CNS lymphoma, right, immunocompetent individual, the primary CNS lymphoma, it is being present as, or it will present as diffuse large B cell lymphoma, right, diffuse large B cell lymphoma, where that is in case of immunocompetent individual. Whereas if you take the primary CNS lymphoma presentation in case of immunocompromised, right, what is this immunocompromised? That is, you take in patients with HIV, or you take in patients with who are on the chemotherapy. In these individuals, the primary CNS lymphoma, it will present as the following. What is that? It will present as the immunoblastic lymphoma. So primary CNS lymphoma in immunodeficient patients like HIV infected or organ transplant recipient patients on immunosuppression is large cell, right, large cell with immunoblastic lymphoma. So this is a very important point you should remember. Which one? Immunoblastic. Now we will move back to our question again. We will move back to our question. So which is the most common type of primary CNS lymphoma in HIV positive? That means immunocompromised. So in immunocompromised, what will be the presentation? The presentation is in the form of immunoblastic, right? The presentation is in the form of immunoblastic large cell lymphoma, right? So this is about the discussion of this particular question. Now we will move on to the next question. We have a 45-year-old man presenting with diminished vision in the right eye. On examination, Marcus gun pupil is noted. MRI head was performed. What is the diagnosis? In MRI, remember, it will be always in an opposite fashion. This is your right eye in MRI and this is the left eye in the MRI. Okay. To make it easy for you, I have just labeled which is right eye and which is left eye. The options are neuromyelitis optica, rhabdomyosarcoma, retinoblastoma, optic nerve glioma. What is the answer? Right. Very good, Ravi. You have answered that as first. That is your optic nerve glioma is a correct answer. Optic nerve, you can see here. This is a space occupying lesion. This is your space occupying lesion. Where is it present? It is present within the optic nerve. And that is called optic nerve glioma. But one point most of the students where they get confused is about the Marcus gun pupil. Marcus gun pupil, it is seen in case of neuromyelitis optica. Neuromyelitis optica, this is also called Devick's disease. Right? This is also called Devick's disease. And this is Devick's disease. This is one of the variant of multiple sclerosis. But what is the presentation of your neuromyelitis optica? Neuromyelitis optica, they will present with transverse myelitis. right? They will present with transverse myelitis, leading to ascending paralysis, right? Leading to ascending paralysis, and they will also have optic neuritis, right? But in the patient, does the patient give you any history of ascending paralysis? No. Any image suggests you of optic neuritis? No. So that is the reason why neuromyelitis optica is gone. Then coming to your rhabdomyosarcoma, the second option. If you take this rhabdomyosarcoma, let me tell you what will be the presentation. In case of rhabdomyosarcoma, this is usually present in the first decade of life, right? First decade of life. And what do they present with? They present with proptosis. They present with proptosis. Now, what is the age which is being given in the question? That is 45 years. So, rhabdomyosarcoma will present in your first decade. So, that itself will make you to think that rhabdomyosarcoma is not the answer. And they will have proptosis. If you take the MRI, there is no proptosis here, right? Next, coming to your retinoblastoma. Let me show you how will this particular retinoblastoma appear. Retinoblastoma, usually that is also the one which is seen in the eye, that is in children, and you can notice that there is presence of proptosis. It is a tumor which is originating from the retina, and most commonly it occurs in the children. And what is the age group given to us? The age group given to us is 45 years. So your retinoblastoma is ruled out. Next. Now, one point I will tell you about what is called Marcus gun pupil. Most of you might be knowing, but those students who doesn't know about Marcus gun pupil, let me tell you. Now, this is the normal eye, right? This is your normal pupil also. You take the normal light reflex. What will happen? For example, you consider this is the left eye and this is the right eye. When you have shown the light to left eye, you will have the constriction of the pupil in the left eye, that is direct light reflex, and you will also have the constriction of the pupil in the right eye, that is indirect light reflex, that is normal. Whereas in case of RAPD, relative afferent pupillary defect, what will happen is whenever you show the light into the affected eye, initially there will be minimal contraction of the pupil, and followed by that there will be dilatation of the pupil. So you see what is happening. Instead of contraction, there is dilatation of the pupil which is occurring. That is called Marcus gun pupil. And there is no consensual reflex. There is no indirect light reflex also. I have explained you what is indirect light reflex. So in case of Marcus gun pupil, in the affected eye, if you show the light, there will be minimal contraction initially, and followed by that there will be dilatation of the pupil, and there is no consensual light reflex. So this is another point what you should remember related to your Marcus gun pupil. And Marcus gun pupil in this scenario is because of your optic nerve glioma. And differential diagnosis for Marcus gun pupil is neuromyelitis optica, but this patient doesn't have ascending paralysis and optic neuritis. So that is the reason why your neuromyelitis optica is ruled out. Okay, so I hope you people are following, right? Are you understanding the session? Right. So we will move on to the next question. We have a patient with a mass in the brain, and he is managed by chemotherapy and radiotherapy. After 2 months, she developed vomiting and headache again. What is the investigation of choice to detect the mass? Contrast enhanced MRI, PET scan, MRI, CT scan. Anyone want to make an attempt of this particular question? She is already taking chemotherapy, radiotherapy. After 2 months, she developed vomiting and headache again. What is the investigation of choice to detect the mass? Okay, very good. Very good, Ravi. So the answer is your PET scan. The answer is your PET scan. Now, what will happen whenever you do this MRI? Contrast enhanced MRI or the normal MRI, what is the disadvantage or what is the problem? Okay. Now, let me explain you. With the disadvantage of your MRI is that is contrast enhanced MRI or conventional MRI, there will be an overlap. There will be a considerable overlap of the findings, and that is the reason why we don't use the MRI for the purpose of making out the mass. But what are the recent methods which have come up to detect the mass? The recent methods which have come up is your PET scan. Not only PET scan, we have many advanced imaging modalities. What are those? We have first and foremost PET scan, as I have said you. Next, MR spectroscopy, that is magnetic resonance spectroscopy. And we have diffusion tensor imaging and perfusion MR imaging. This is your advanced imaging modalities. So with the help of this advanced imaging modalities, you should be able to make out the mass where you have given already radiotherapy and as well as the chemotherapy, right? So the answer to this particular question is what now? That is your PET scan, not your MRI or CT. What is the disadvantage of your MRI or CT? There will be an overlap which is present considerably. There will be an overlap which is present considerably. Okay, then we will move on to the next question. Yes, very important question. We have a patient presenting with unilateral painful ophthalmoplegia. Imaging revealed an enlargement of cavernous sinus on the affected side. What is the likely diagnosis? Gradenigo's syndrome, cavernous sinus thrombosis, Tolosa-Hunt syndrome, orbital pseudotumor. Yes, anyone? Anyone want to make an attempt of this question? Yes. Any one of you, please? Right. So let me answer this question for you. Some of you have answered it as Gradenigo's, some of you have answered it as cavernous sinus thrombosis. Okay, but let me tell you what exactly is the answer. The answer is Tolosa-Hunt syndrome. Why it is Tolosa-Hunt syndrome? Let me explain. First, coming to your Gradenigo's syndrome. What does this Gradenigo's syndrome present with? This particular Gradenigo's syndrome, it will present or it is characterized by a triad. Now, what is a triad in Gradenigo's? Number one, otitis media, right? Otitis media. Number two, the presence of the facial pain, right? Number three, presence of sixth nerve palsy, right? Presence of sixth nerve palsy. These three are the triad of your Gradenigo's syndrome. And why does this Gradenigo's occurs? This Gradenigo's syndrome will occur mainly due to infection in the petrous part of the temporal bone. Right, mainly due to infection in the petrous part of the temporal bone, you will develop this particular Gradenigo's syndrome. So your Gradenigo's is ruled out now. Whereas you take the cavernous sinus thrombosis. Cavernous sinus thrombosis, what is the most common symptom in cavernous sinus thrombosis? Anyone want to answer this? What is the most common symptom in cavernous sinus thrombosis? Let me tell you, the most common symptom in cavernous sinus thrombosis is your headache. Right? It is your headache. And headache is not mentioned in your options at all. What is just mentioned? There is a mention of just unilateral painful ophthalmoplegia, and imaging revealed enlargement of the cavernous sinus. Okay. Now, headache is not being mentioned. Now, what are the other features of this cavernous sinus thrombosis? Let me tell you. The other features of cavernous sinus thrombosis, CST stands for cavernous sinus thrombosis. Headache is the most common symptom, and they will also have focal neurological deficit. They can also have seizures, that is another feature of cavernous sinus thrombosis, and they will have isolated third nerve palsy. Isolated third nerve palsy, it is the early manifestation. Right? It is the early manifestation. Now, what will be the orbital signs in cavernous sinus thrombosis? Orbital signs, you will have chemosis, right? And you will also have exophthalmos. Exophthalmos is another important feature in case of the cavernous sinus thrombosis. Now the question is, what does the CT scan shows? The CT scan, it shows the high density thrombus. Where will you have this particular high density thrombus? In the cavernous sinus. Right, it will show high density thrombus. Now, whatever the features I have discussed about the cavernous sinus thrombosis is not there in this particular question. Is not there in the question. So that is the reason why your cavernous sinus thrombosis is ruled out. Only one point, revealing enlargement of the cavernous sinus. That itself will not tell you cavernous sinus thrombosis. Now, why is it this Tolosa-Hunt syndrome? Let me explain you. Now, first of all, you should know what is this Tolosa-Hunt syndrome. Tolosa-Hunt syndrome, as such, this is one of the rare disorder. But what will be the manifestation? They will have headache with orbital pain. That ophthalmoplegia, whatever is there in your question, is nothing but your orbital pain. And they will also have the paralysis of your extraocular muscles. Paralysis of extraocular muscles. And what does this MRI shows? MRI will reveal enhancement of the cavernous dura. See, this is your cavernous matter, cavernous sinus. Around the cavernous sinus, you have the dura matter. And this particular dura matter have been completely thickened. And that is what is the representation, what he is giving here. Enlargement of the cavernous sinus, whatever he is telling you, is nothing but the thickening of the dura matter which is present around the cavernous sinus. So that is an important point of the discussion there. So that is the reason why the answer is your Tolosa-Hunt syndrome. What about orbital pseudotumor? How do you rule out orbital pseudotumor? In case of orbital pseudotumor, the very important manifestation is presence of sudden painful proptosis. Sudden painful proptosis is the feature what you will have in patients with orbital pseudotumor. That is not given in our question. So even your orbital pseudotumor is also ruled out. Okay. Now, this is about this question of the Tolosa-Hunt syndrome. Tolosa-Hunt syndrome, you should be very much aware of, because this is a very, very important question. Next, I will take up the last question for the discussion. Yes, if you see this question, CNS tumor in von Hippel-Lindau syndrome is meningioma, cerebellar hemangioblastoma, CNS lymphoma, and glioma. Can anyone answer this question? Meningioma, cerebellar hemangioblastoma, CNS lymphoma, and as well as glioma. Right. Very good. So the answer here is cerebellar hemangioblastoma. The answer here is cerebellar hemangioblastoma. Now, if you take this von Hippel-Lindau syndrome, what is your von Hippel-Lindau syndrome? Remember, this is one of your autosomal dominant disorder. right? This is one of your autosomal dominant disorder, right? And this is also one of your neurocutaneous disorder. And there are many tumors in your von Hippel-Lindau syndrome. What are many tumors in that von Hippel-Lindau syndrome? You have the tumors of the kidney. This is most common, 75%. And there are also presence of multiple cysts in von Hippel-Lindau. Next, the other tumors in von Hippel-Lindau is liver and spleen, pancreatic cyst, renal cell carcinoma, cerebellar hemangioblastoma, retinal angioma, pancreatic adenocarcinoma, epididymal cyst adenoma, and pheochromocytoma. So these are the multiple tumors and as well as cysts what you will see in this clinical scenario of von Hippel-Lindau syndrome. Okay, now, so lastly, let me tell you that what all will be the features of your plus hours, because once you subscribe to this Unacademy platform, you will become a plus student. You can attend all the live sessions and you can attend the test series and as well as the quiz. And we also have a separate doubt clearing sessions one-on-one to each and every student. And these are all the list of courses what we have in the month of March. There are totally 48 courses, and if you subscribe even for one course, you will be eligible for all the courses. And for subscription, if you want a discount, you can use my code, that is Raj1769, right? Yes, Vipul. The eye tumors are also called retinal angiomas. Yes, we can call that. Okay, fine. So, right. So, I hope you people have really enjoyed this particular session. I think I have given you some extra points which you are not knowing previously. Yes or no? Fine, very good. So I'll just end my session right now. And again at 10 o'clock, I have one more session on the same YouTube, which or wherein I will be coming up with the questions related to neurology again. So we will have a great discussion again at 10 o'clock on this Unacademy platform, that is on YouTube session. Thank you very much and see you at 10 o'clock.